My name's Anne-Marie Papa, and for those of you who don't know me, I have the great pleasure of being the director of the emergency department at Doylestown Hospital. I have a bachelor's degree and a master's degree from Villanova, and I am in the doctoral program with there are three esteemed colleagues here, and they'll do their introduction as they come up. We're going to talk a little bit about what is the rationale for treating pediatric pain. And really what we're talking about more is pediatric procedural pain. This is not a conscious sedation lecture. It's how you can make your procedures more comfortable for your pediatric patients. We're going to go over a little bit of the National Physician and Nursing Standards, and I'm going to show you what standards are out there from INS and the Pediatric Society, of course, the American Pain Society. And we're going to go over some of the pharmacological agents that are out there and how you use them and when you use them. We're going to go over some opportunities that you may see for your practice, and then we're going to do a little bit at the end of a cost comparison. So to get us started, I thought this is an interesting slide. It talks about the physician guidelines and support of managing procedural pain. And as you can see, the American Academy of Pediatrics and the American Pain Society, they say local anesthetics and strategies should be considered, even for simple procedures such as venipuncture. The next one is the American Academy of Pediatrics, again a physician society, speaks to topical anesthetics and again should be considered on invasive procedure and intact skin in the emergency department. And you're going to hear a little bit later from Mary Jo and Denise about using agents on unintact skin for lacerations and boils and things like that. And also the International Association for the Study of Pain. The Infusion Nurses Society write down local anesthetics should be considered. The American Association of Critical Care Nurses, they're our friends in ICU, CCU, PICU, they say to assess the child's and family's previous experience and again consider a topical anesthetic. And the third one here, the Emergency Nurses Association, we do not have anything specific at the present time. However, you can see that there's a resolution in process. If I asked all of you out here, we had a focus group before, and pretty much the same thing came out. Why do you not use a topical anesthetic? What would be your number one reason? Time. But in an emergency department, when you're putting a line in a child, it's really an emergent procedure and you need to get it done and get it done quickly. You don't have time to be putting the cream on or anything that takes a long period of time. And the other thing with that is you have to remember if you're going to do something with a child, you want to do it in the shortest time possible because you don't want them to have time to think about it. How can we make the procedure less traumatic? If we can do something in 3 minutes, and if we can do some education and some pain management, we can save 20 minutes on the back end. So I'm going to pass it over to my colleague Denise. Thank you very much, and I'll be back at the end to wrap us up.
My name's Denise Ramponi, and I've been a nurse practitioner for 20+ years in the Pittsburgh area, and I currently work at 2 busy emergency departments at Heritage Valley Health System, which is Beaver and Swickley. And my section is really to talk about establishing trust with the child, how to position the child, what to say to the child, and then how to distract the child. The biggest thing I think to learn with any child is really to give them a choice about something. If a child feels that they're participating in that care, it makes them feel empowered. If at all possible, always allow the parents to remain with the child, with the caveat that we know some parents really can't handle the situation, so sometimes maybe mom has to leave but dad can stay with the child. As far as distraction techniques, whether you have the parents tell a story, you have a toy there, or squeeze the parent's hand, or whatever you have, whenever you use a negative word with a child, it really invokes fear in the child. So if you can avoid the words that are not and don't, so by saying things that you want them to do, that's the best way to advise the child. And you know, you don't want to really lie to the child at any point because then the child may mistrust you. But you know, you want to use words that will make them feel a little bit more secure.
My name is Mary Jo Serapani. I'm a nurse practitioner for UPMC. I work in 15 emergency departments as a floating nurse practitioner, and I am the liaison for UPMC's emergency departments. Painies, this is used for injections, childhood immunizations, flu shots, any allergy shots, pre-lidocaine injections. It's great for IV starts, venipunctures, minor surgical procedures. This has been the best thing that happened to us because it acts very quickly. Emergency departments, as a nurse practitioner, I will allow, I'm not really taking care of the trauma patients, I'm taking care of the non-urgent patients, most of the lacerations of the children. So nurses do not like to wait. They want to work quickly when we're doing IV starts. So when they heard about pain ease, this was great because we can act very quickly and use it immediately. It lasts for 60 seconds. We can have the IV inserted or the blood drawn. So if I'm doing an injection, a dental block, I can use it as a dental block. If minor open wounds such as scalp lacerations, I don't even have to inject with lidocaine. I just cleanse the wound, spray it over, cleanse it, and place the staples. Works immediate. Lasts for 60 seconds. The staples will be in. Also abscesses, spray it over the abscess, IND the abscess. I don't have to even inject the patient. So it works very quickly. So the cost comparison will be over to Rhonda Morgan.
Gebauer's Pain Ease. Important risk and safety information. Published clinical trial results support the use in children 3 years of age and older. Do not use on large areas of damaged skin, puncture wounds, animal bites, or serious wounds. Do not spray in eyes. Overspraying may cause frostbite. Freezing may alter skin pigmentation. Use caution when using product on diabetics or persons with poor circulation. Apply only to intact oral mucous membranes. Do not use on genital mucous membranes. The thawing process may be painful and freezing may lower resistance to infection and delay healing. If skin irritation develops, discontinue use. Gebauer's Pain Ease is prescription only.
Thank all of you for being here. It is my dubious honor to end up this presentation talking about cost. So I don't want that to be a downer, but just a couple words about me. I spent most of 2 decades in an ER, and since that time, actually I'm still in direct reporting line for ER. Also have had experience in critical care and advanced practice role as ClinSpec in Neuro ICU, and currently I'm Vice President for Clinical Services at a Level 1 504-bed hospital in East Tennessee. Before I talk about cost, because that's a little bit dreary, so we'll get there in just a minute, I want to say just a few comments about the study, and it was called Compassion, Contentment, and Competency in Managing Children's Procedural Pain. It was a very large study. 96% of the time we do something, but we really know that it's not enough to do. And my colleagues have already talked about all the data that has backed us up and lets us know that pain experienced as a child can cause long-term traumatic distress disorder, even in adults, in ill-managed pain. So when we can find a product that reduces our costs and still achieves the therapeutic advantage we're looking for, the time-saving advantage we're looking for, that does not increase the harm to the patient, then we know that there are decisions we need to make in that direction. Usually there's a question, and if it hasn't been asked yet, you're probably thinking about it. How do I charge for these products? Who's thinking about that question? If you're in the management role, you probably know that. For Pain Ease as well as these other agents, they are bundled much of the time in your charge master, in your E&M. So that's the way you would bundle that charge into the procedure. And since Pain Ease is a medical device and not a medication, as by FDA, it could be bundled into the procedure, and then you charge by the procedure in your charge master. Thank you very much, and I think Anne Marie's going to wrap us up.
We had a focus group before this dinner, and we talked about some of the goals over the next year. And one of the goals is looking at the possibility of putting on a national education awareness program for the nurses, to give them, and nurses, patients, parents, whoever the audience might be, to raise the awareness of the fact that there are things that we can do to reduce the pain associated with peripheral venous access or minor surgical procedures. In your Press Ganey surveys, you're asked, how well do you manage pain? How well did the person who was putting your IV in, what was the skill of them? And how does a patient rate your skill? Because this is an issue that nurses can make a huge impact on the patients, on the care of the patient, and on your Press Ganeys. And let's think about it. We're going to be paid based on our Press Ganey or our patient satisfaction as well as our outcomes soon. So I think Denise talked a little bit about empowering the nurses, and things like this enable you to really make a difference in the lives of your patients. And I hope something as simple as this helps you understand how you can own your practice, how you can go back to your organization and make a small change. But that small change has a huge impact on how we care for patients. It's been my pleasure and my honor to be up here with you today.
Myth is that children have less pain than adults. Don't think that. Really, they do have the same pain as adults.
One bad experience can end up with a lifelong fear.
So if we can do something to reduce that, I think we nurses want to step up to the plate and make that happen.
Most of all, take this back home and let us start changing practice for all the good reasons we know we should.